Okay. Good afternoon, everyone. I guess it's past noon, and I'm Dr. Joe Kent. I'm an interventional pain doctor, and I have my colleague here, Dr. Dan Blizzard, who is an orthopedic spine surgeon. And we're going to be talking to you today about a very common topic, basically bulging discs and degenerative disc disease. So without any further wait, we're going to go ahead and get started. So the title of the talk, bulging discs, causes, symptoms, and treatment options. So what is a bulging disc? So a lot of people, you've probably heard from your doctor or friends that they have a bulging disc, and that's why they're having pain in their back. And so we're going to kind of talk about, well, what does that mean? And this term bulging disc is also known as a herniated disc, a herniated nucleus pulposus, slip disc, ruptured disc. These are all kind of flavors of similar related disc-related issues. If you look at the picture, you can see kind of what happens to your spine over the course of living. The fact that we have gravity and this constant downward pressure on our spine causes degeneration. And so degenerative disc disease is essentially just your body's going through some wear and tear, and you're living under these conditions. A bulging disc is kind of a subset of that. So if you look at the top of the screen, you have your normal disc, which has a specific height that you were kind of born with. Over time, these discs start degenerating, which essentially is a radiologic finding that says the discs, they're not as hydrated well, and they're looking a little darker on MRI, or there's not as much space between your bones and your back. And so what can happen is that can progress then further to a quote bulging disc or a herniated disc. And then if you look towards the bottom of that graphic, you can kind of see some other things that can happen as a result of basically degeneration or arthritis of your low back. So what does a disc do? So a disc is made up of the nucleus pulposus, which is kind of this gel-like material in the center of the disc, and then you have what's called an annulus fibrosus, which is essentially a very tough connective tissue that keeps all that gel material inside your vertebral body, or inside that disc space. But what the disc does, in essence, is a spacer. It keeps all the nerves that are exiting the spinal cord at particular levels, keeps those spaces open, and so the bones don't collapse on the nerves. It also acts as a shock absorber. So when you're running, when you're jumping, basically what the disc is doing is it's taking that force, that downward force, and kind of distributing it equally throughout your spine, so you don't break any bones, or you don't have any fractures or pinching of any nerves anywhere. It's also a motion unit, which means that it allows you to move. And that kind of, well, we'll get there, but what causes a bulging disc? We briefly touched on it earlier, that it's kind of on a continuum of degeneration of your spine, or of your disc material. And what happens is, as you age, these material with forces, gravity, different axial loads, meaning downward force on your spine, that can cause over time your spine to get arthritis and have these materials not be as elastic as they once were. And what can happen is you can have different tears of that annulus fibrosus that we talked about, which can cause that disc, that internal nucleus pulposus, or that internal disc material, to kind of spill out in any one of different directions. And the one that typically causes pain is if it spills out onto the nerves or the spinal cord. And this can occur, not only does it occur with arthritis and kind of just a normal degenerative process of the spine, but if you have any sort of trauma, falls, motor vehicle accidents, any sort of heavy weightlifting, any sort of axial load, meaning downward pressure on your spine, then that can cause these disc material to kind of protrude out. Some factors that speed up degeneration. So if you have a job where you're doing a lot of manual labor, you're doing a lot of lifting, bending. We see this often, in the people who are in the military. That can speed up the degenerative process of the spine. Some people, just for whatever reason, genetics play a big role, and they tend to have degeneration in their spine more quickly than others. Trauma, like we mentioned earlier, obesity is a big factor in the United States, because you can imagine if the more weight that you're carrying, that weight It gets all transmitted through your spine, down through your hip joints, your knee joints, and so that's why those with obesity, those joints tend to break down more quickly and can cause pain and arthritis. And then, weak core muscles is another, if the back muscles, the stomach muscles, you want to make sure that you're balancing your spine in an appropriate way and basically having all three joints of your spine, which includes the disc and the two facet joints, which are often ignored in the back of your spine. Make sure that those forces are all balanced equally. So where do they occur? They're much more likely to occur in the cervical spine and the lumbar spine. And the reason is it kind of gets back to what we were talking about earlier, is those are where your body, your spine has motion. And so those discs tend to basically take more strain because you're moving your head, you're moving your low back, bending over, and that type of thing. And that's why people tend to have neck and low back pain. Some other, talking about the thoracic spine, you'll hear people say they have a thoracic spine disc bulge. Well, that can happen because you are still having those downward forces in the thoracic spine, but while it's not as common to have any significant disc bulge in the thoracic spine, it's even more rare for these disc bulges actually be pressing on the spinal cord or causing nerve pain or pain-related issues. And so that would be thoracic spine degenerative discs or bulging discs are very uncommon to actually be causing symptoms. So that gets us to the number one symptom of a bulging disc is no symptom at all. And so just because you have a degenerative disc, you hear it on your MRI report, it doesn't mean that that's what's causing pain. We'll talk a little bit more about that, but the number one symptom, this is a big take home I think that you want to take away from this talk, is a bulging disc, a herniated disc. The most common symptom is no symptom at all. So, but if a bulging disc, like we talked about earlier, if it is to contact the spinal cord, if it contacts the nerves as they're exiting the spinal cord, they can cause things called radiculitis, radiculopathy, or colloquially you might hear from your primary care doctor or a friend that they have, quote, sciatica. And basically what that means is you have, well, for sciatica, that you have pain shooting down your leg. And so if a disc contacts the nerve, contacts the spinal cord, it can cause these acute symptoms from a recent disc bulge, such as burning, shooting, electric pain that goes down the arms or legs. It can be associated with numbness, tingling. If the nerves are really pinched, it can cause weakness in very specific patterns. Sometimes if the disc is pressing on the spinal cord itself, you can have worsening low back pain when you stand up tall, and sometimes it gets better when you lean forward. And these are all can happen in kind of the acute period. We'll get to that. The chronic symptoms. So, from a definition standpoint, chronic pain means going on greater than 3 months. But those same symptoms, the same acute symptoms, can persist. Sometimes the symptoms can kind of start coming back and kind of being more just kind of a dull neck or low back pain. Sometimes if the nerves are damaged, that can cause weakness in specific muscles, and you can actually start seeing muscle atrophy on various muscle groups. So pinched nerve in the neck, like I talked about, usually comes in very specific patterns. As you can see from this graphic, these are kind of the classic areas where these various pinched nerves are felt. And so when we, as Dr. Blizzard and I, when we think about patients who come in with pain shooting down the arm, pain shooting down the leg, these are kind of the things that we're thinking about. Does the pain that you have, does it match an MRI finding? Does it match some of these physical exam findings that suggest that that specific nerve is causing the issue, or is it something else? Because a lot of these pain syndromes, they overlap. It can be very difficult sometimes to discern which pain or what is the primary cause of the pain, or is it a combination of things. So here is the kind of the classic area for cervical spine, from C3, C4, C5, C6 starts getting down into the arm, C7, C8, C1, all down through the arm there. For the low back, we have a similar pattern, and you can see from this graphic that, from the L1, L2 is typically, upper groin, thigh. L3, you start getting things going down into the medial thigh and maybe down the leg a little bit. And then we start talking about the lower lumbar nerves, and we start looking at things going down into the lower leg and the feet. And so while these aren't perfect, as far as, not everyone follows the classic presentation, these are kind of a good guide as far as helping to determine what is causing pain and what's the main factor going on. But we can't ignore that the disc can be painful too. And when we talk about treatment, we'll talk a little bit more why the discs kind of get overlooked. But this disc pain can be vague, it can be dull, it can be sharp, usually worse with flexion. As you can imagine, if you're bending forward, your disc is on the front or the anterior, the front part of your spine. And so when you bend forward, you're putting more pressure on that disc. And so that can be a symptom associated with it. Sometimes it's worse with prolonged sitting, standing. If you, classical view, if you lay down, you're not putting as much pressure on that disc, and so your symptoms should get better. But that, like I said, doesn't always happen. And sometimes you can even have pain, referred pain, down to the thigh and all the way to the knee even. So now that we kind of talked about symptoms, a little more on the anatomy side of things, we're going to focus the next portion of our talk about treatment options. And I will kind of lead the first 4 of these bullet points, and then Dr. Blizzard is going to talk about what he specializes in, and that's the surgical care of various pain and injuries. So treatment options. First thing is time. Most bulging or herniated discs will often get better with time. This can take weeks, it can take months. If you get an MRI, and now if you get a similar MRI in 6 months, 9 months, it could look completely different. And so that's why these bulging discs, and when we find them on MRI, sometimes they're these red herrings where we see them, we acknowledge them, but you can't always blame pains on these various findings. But at least anecdotally, more likely to get better when you're younger because that disc material is a little more elastic, it's got a little more hydration to it, and obviously avoiding these risk factors. So if you have a job that demands that you are lifting heavy machinery or lifting things, putting your body in awkward positions, avoiding those things can help. If you've gained a little more extra weight during this coronavirus pandemic, helping get some of that weight off is going to reduce the amount of force on your spine and help kind of promote these discs from starting to herniate out and actually pinching nerves and that type of thing. Conservative therapies. This is kind of also one of the mainstays of treatment of degenerative disc disease and these bulging discs, because physical therapy, chiropractic care can both basically use various manipulations and strengthening exercises to help kind of lengthen your spine, to help that disc kind of promote it getting reabsorbed. They can also strengthen those core muscles. So make sure that you're not putting a disproportionate amount of stress on that disc itself, and making sure those, especially the back muscles, which often get ignored, are strengthened to agree that you're not putting undue amount of pressure on those discs. One thing that can be helpful from a pain standpoint is acupuncture. It's Chinese medicine has been around for centuries, and the reason it's been around for centuries is because there is evidence it works. And so if you haven't tried acupuncture, it's worth try. It's not going to cure everything, but a lot of times for pain relieving, these different pain modalities, you're trying to find an incremental improvement in your pain. If you have chronic pain, rarely, the longer you have chronic pain, the less likely we're gonna find something that's going to take it all away. And so a lot of our therapies that we're dealing with are going to try to do incremental improvements of the pain to try to get you more functional and basically enjoying life. So pain doesn't take over your life. Medications. These are, medications. There's, a lot of things out there today. Typically for, when I try to think of medication therapy for pain, I try to think about what is the underlying cause. Medications such as NSAID medicines, meaning these non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, naproxen, Meloxicam, Celebrex, these are all very specific for inflammation. And so when I'm thinking that a patient's pain is more likely due to, arthritis related component, then those are the beginning of medicines that I recommend, and they work well. Everything's got its limits and everything has risks. You can't get something for nothing. And so, NSAID medicines, they can, if you take them chronically, can increase your risk for stroke, they increase your risk for heart attack. They can also, they can cause a GI upset, ulcers, they can damage your kidneys. And so all these things, if you have a history of any of those problems, then usually NSAIDs aren't a great option. Or if you need an NSAID and it provides significant relief, then oftentimes you'll need to have a little more monitoring. But those are NSAIDs. As far as the next two, gabapentin, pregabalin, those are both anti-neuropathic pain medicines. So they for when nerves get pinched, they'd classically cause neuropathic pain or nerve pain. And so both these medications, how they work is they basically slow down how quickly those nerves are firing. Is when those nerves get damaged, they get irritated, they're firing quickly, telling your brain to pay attention. And so what these medicines do is they kind of slow down that nerve firing. And those can be very helpful for managing chronic nerve-related pain. But again, they can have side effects, and oftentimes they can cause you to be a little sleepy, a little dizzy, they can cause some swelling, forgetfulness, that type of thing. And so while they have some value, you have to look at, in the long term, there's going to be the risks and benefits that are going to need to be balanced. Duloxetine is another medication that you may see people on. It's classically has been used as an antidepressant, but there's been evidence that it is helpful for chronic pain-related issues, especially chronic neuropathy. And so that is another medicine that you may see people get put on for chronic pain. And that, again, is another medicine that can be helpful. So we're going to cross from medications over to more of an intervention. And this is kind of the main focus of what I do. And one of the bread and butter kind of techniques, and one of the earliest things we'll reach for in the tool bag are these epidural steroid injections. And what they are is that basically putting a needle along this epidural space, which is not in the spinal cord, it's actually outside the spinal cord and where that spinal cord sits, and injecting a steroid medicine to basically deliver a very high concentration, a very potent steroid right around those nerves that are irritated to help reduce the inflammation and the irritation of those nerves. People will often ask me, how long is it going to last for? Well, I tell them it kind of lasts as long, it depends on what's the underlying issue. If you had an acute or recent herniated disc and it's on its way to getting better, like they often do, often these epidural steroid injections will buy time, get you out of severe pain until your body just heals itself. Sometimes when you have chronic nerve pain, these epidural steroid injections, they give you enough relief where you can get months of relief out from the injections, and then we just do those periodically to keep you functioning. And so these are great procedures, for patients with these nerve-related pain issues from bulging discs or herniated discs that are pushing on nerves. Okay, I want you to focus on that, pushing on nerves. When we talk about degenerative disc disease, this is kind of something that's very hot right now, our bone marrow stem cell injections. So what that entails is if you think that the disc itself is causing pain, which we talked a little bit before about discogenic pain, it is a real thing. And unfortunately, why we're still trying to figure out how best to treat discogenic pain. We've tried a number of different therapies in the past, from injecting steroids, other medications, tried burning the disc, all these type of things, and the literature and the studies haven't borne out that those actually help. Bone marrow stem cells we're on the verge of understanding what these procedures and what these stem cells can provide. But this is a promising procedure that has some good data that shows if you inject stem cells basically into this disc material, then that can help with pain function. And that can actually, they've shown that there's been shown some MRI evidence of improved disc, how the disc look. typically before we'd consider these bone marrow stem cells, and sometimes when the surgeons are concerned about a disc, they'll ask us to do what's called a discogram. If you look at the picture on the far right, that's basically, you'll see needles that are inside these various discs. And basically what I do during a discogram is inject some dye and ask you, is that what's causing your pain? They're not pleasant procedures, but their goal is to identify which disc is the culprit, which disc is causing the pain. And then based on the results of that, that can help the surgeon plan their surgeries. That can also help me, if we're considering doing bone marrow stem cell injections into these discs, identify which discs need to be injected. Because you don't want to inject all the discs, because anytime you put anything through the body, anytime you put anything through the disc, you're introducing risk. And risk for getting infections into these discs can be devastating. And so you want to make sure that there are benefits, potential benefits, before you start injecting substances into these discs. And so that's why these discograms are helpful. That one study that I briefly talked about was looking at discogenic back pain. They had very specific criteria that they were signing patients up for, and they basically had a MRI at baseline, and they got a baseline at 12 months, and they did 7 of the patients ended up having these discograms to try to figure out which disc was causing the pain, because it wasn't clearly obvious on the MRI, and they ended up enrolling about 26 patients. And what they found is that actually 24 patients, so 92%, avoided surgery at 12 months. So their pain and their function was improved to a degree that they didn't feel like they needed to progress to surgery. 21 of those at 2 years decided that they didn't need surgery. And so you can see that's still 5 patients that decided this didn't help, and they still needed a more traditional intervention, like a larger surgical procedure to help with the symptoms. Of the 21 patients that made it through to 2 years, they found that their disability and pain scores were reduced by 70%, which is a great number. And that this one thing that was very positive is this MRI finding, where they showed that there was actually improvements in an independent radiologist reading an MRI that showed an improvement in 8 of the patients at various discs that were injected. And importantly, none worsened. And so that is some reassuring and some good information that maybe this is help actually regenerating and help kind of healing the disc in some way. And most importantly, there were no complications associated with this procedure. And so this is an option, but it's not for everyone. Something that is new-ish in the last 5 or 6 years is this procedure. It's a vertiflex procedure. And what that can help for is for patients who have discs that are bulging or herniating and actually pushing on the spinal cord itself, or the nerves as they're coming down through the lumbar spine. That can cause very specific symptoms that makes it difficult to stand and walk, and you start getting heaviness, weakness in your legs. And so an option that I have been a huge fan of is this vertiflex procedure. And what's nice about it is it's a minimally invasive procedure. There's very little downtime, and it's not a substitution for surgery by any means. But oftentimes this little device can give patients enough room along their spinal cord where hopefully they never need to progress to having a larger surgery. But if they do, the surgeon, like Dr. Blizzard here, can, on his way to doing a surgery, can just pluck out that little device and continue on his way, and this doesn't change the anatomy of where he'll be working. And so this is a great option, very minimally invasive, very short recovery time, outpatient surgical procedure that can significantly help patients' symptoms of lumbar spinal stenosis without having a major surgery. And so this is an option for discs that are, like I said, are bulging backwards towards the spinal cord. And the last thing that I'm going to talk about is spinal cord stimulation itself. This has been around since the 80s. There has been an explosion of technology just within the last 10 years or so, looking at various waveforms, different ways of delivering energy. But what essentially it is, as you can see up in your upper right-hand picture, you have some leads, which are basically little flimsy kind of spaghetti strings for the most part. The ones on the far left are paddle leads, and those are a little different. But spinal cord stimulation is a therapy that delivers energy to the spinal cord itself to kind of block those pain signals from basically reaching your lower extremities or your arms from reaching your brain where you perceive pain. They also kind of downregulate or decrease the sensitivity of those nerves as well. And so that can be a way for patients who can't really identify a surgical issue or something that can be readily fixed. This can offer patients substantial relief and long-lasting relief for their chronic pain in their low back or their neck or arms, that type of thing, or their legs. There are a bunch of different companies out there. They all have kind of their special flavors, but they all work in a similar way. They just, like I said, have different flavors. But this can also be a very good option for patients who have this chronic pain. So with that, I'm going to pass it off to my colleague, Dr. Blizzard, and he is going to continue on.
Perfect. All right, that was a very thorough introduction to a relatively big topic that encompasses majority of what we do here in treating the spine. So I'm going to narrow my scope down a little bit and talk specifically about surgical treatments for people with degenerative disc disease. This is that category of people without instability, without stenosis, but just discogenic back pain. So again, we'll talk a little bit about how the other things are treated, but for the scope of this, I want to talk about discs that have no instability and no pinched nerves. So among that subset of people with spine disease, when should you consider surgery? Well, when you're at your wit's end, when nothing you've tried before has helped and you've tried working at this for 10 years. Frequently, we're told patients are told that they have the worst back to their primary care doctor, their chiropractor, therapist, friend, relative. It's the worst they've ever seen. And finally, in general, as a surgeon, I'd want to hear a patient tell me that if there's even a 1% chance that surgery would help you, you'd want to go for it. And it seems like pretty dire straits, but I'll get into more detail of why we reserve surgery for the last possible minute when it comes to treating disc disease without any pinching of the nerves and without any movement of the bones. So surgery, like I said, are you really sure? Think twice, I think twice again. I think everyone's probably heard the adage of if you're a hammer, everything looks like a nail. Well, as spine surgeons, we often look like hammers, and every person that comes into our clinic looks like a nail. So if you want to get a spine surgery, be careful asking a spine surgeon about it. So diagnosing back pain. There are multiple causes of back pain. We talked about this already. Dr. Kent covered this in good detail. There are stenosis. So this is the pinching of the nerves. This can be in the spinal canal or pinching the nerves as they leave the spinal canal on the way to your body, in what's called the tunnels or the foramen of the bones. Instability. This is bones moving in an abnormal way. This can be bones sliding forwards and backwards, left and right, or bones that are aligned in an abnormal way. People with scoliosis or people with very bad posture that are tipped forward. The next category, when you don't have stenosis, don't have instability, is just degeneration. This is, in general, normal aging. This affects the facets. These are the small joints in the back of your spine, and the disc, the big joint at the front of your spine. And like we talked about, every level of the spine is set up like a tripod, where there's a big disc in the front and two supporting joints in the back. And all three of those are important. If you remove any one of those joints, it becomes unstable. The next category of back pain is the SI joint. It's the great mimicker. Many things can look like back pain, but really be SI joint pain. Leg pain can also be SI joint pain. It's a diagnosis you often have to eliminate everything else first and end up saying, maybe this is the SI joint. And the final category is lumbago, which is the true diagnosis of exclusion, which means low back pain of unknown cause. So the first category here, spinal stenosis. This is a very common term. Almost everybody who's ever ventured into a spine clinic has heard this term. This is compression of the nerves either in the middle of the canal or as the nerves leave the spine on the way to your legs or your arms. And when it's in the middle of the canal, we call it central stenosis. When it's pinching on the side as the nerve leaves, we call it foraminal stenosis. This creates buttock, hip, and lower extremity pain, weakness, and numbness. And in the upper extremities, it creates arm pain. Symptom-wise, you can have any one of these symptoms independently when I talk about pain, weakness, or numbness, or you can have combinations of them together. It doesn't have to be one or all of them. Frequently, this lower extremity pain comes with low back pain. Spondylolisthesis, it's a big Latin term which means instability. This is the slip disc you've probably heard talked about. The bones in your lumbar spine and your cervical spine should pivot on each other as a bushing joint. So they should pivot, but they should never slide in either direction relative to each other. If they do, it is almost unavoidable for that to be uncomfortable. And when that happens, people will frequently say, I feel comfortable when I'm laying down, and the minute I stand up, I immediately have back pain and leg pain, and the minute I lay back down, it feels more comfortable. And the reason why, as you can see in the picture, in this picture, the L4 bone is sliding off the L5 bone. So when this person stands up and gravity pushes down on their spine, the L4 bone is going to want to be pushed further forward, which is going to grind the bones together and also tug on the nerves. So this person's going to say, most likely they feel better laying down. There are multiple potential causes of this, the most common of which is degeneration or just normal aging. And what patients get this? Why does one patient who's 65 years old, who's worked a very hard life, get this and one does not? Unfortunately, that comes down to bad luck with genetics. Some people are just predisposed to have their spine break down in this way. Instability, the category here encompasses multiple different forms. Spondylolisthesis, we already talked about. It's probably the most common form we see. Fractures, anytime you break a bone, you lose the integrity or support of your spine. Hypermobility, people that have connective tissue disorders where their body is more lax, their muscles are weaker, and their spine can adopt an abnormal position. Scoliosis, this is a fixed position where your body has abnormal curvature and or rotation. And then on the smaller category is infection or cancer, where you have a process going on that weakens your bone, weakens your disc, and makes your spine collapse in a certain way. So patient selection, this is by far the most important aspect of picking patients for surgery. It's not necessarily how severe things look on imaging. It could say severe degenerative disc disease, it could say mild. It's all about the symptom the patient has, how it's affecting them, and what they've tried so far that has or has not worked. So as a surgeon, we break patients down into three big categories. The first category is patients with stenosis. This is pinching of nerves. These people say, my legs hurt, my back hurt, my arms hurt, and frequently there's a pattern to this. Well, they'll say a certain position it feels better, certain position it feels worse. Stenosis needs a surgery that frees up the nerve. That can be either doing what's called a laminectomy or a decompression, and sometimes it's done with or without a fusion. So if somebody's bones are collapsed and sliding in a certain way, it can be pinching the nerve because the bone has become unstable and it's pinching the nerve. So that patient would need a fusion to restore stability and possibly a decompression to hollow out room for the nerve so it sits in a tunnel that it's happy in. The next category is instability. So people that show up with bones moving in an abnormal way. In general, patients with stenosis need a decompression surgery. Patients with instability need a fusion surgery. And more recently developed ways of establishing stability without fusing people. This is disc replacement, and more recently than that even is facet replacement. The final category is degenerative disc disease. Again, degenerative disc disease is a broad term that describes essentially all of degeneration in the spine. But for the purposes of this talk, I'm talking about people who don't have stenosis, who don't have instability, neither one of those, but instead just have degenerative unhappy disc and pain from the unhappy disc. The solution to this surgically is doing a disc replacement or a fusion. So the goals for that, number one, obviously, is to remove the pain generator, and two is to restore or at least maintain the disc height in the space of the nerves. That's the canal and the foramen where the nerves leave the spine. Again, keep on saying it, this excludes stenosis and instability, which is 99% of what we operate on. So this is the 1%. As surgeons, these patients should occupy 1% of your practice or less. Again, this is something we consider after everything that Dr. Kent talked about has failed. Again, this is the discogenic type pain that we want to prove with a discogram. This is when stem cells don't work. This is when every injection or non-operative therapy, physical therapy, medications, when none of it works, then you fall into the surgical category. So within surgery, the options for degenerative disc disease is, do you fuse it or do you replace it? And I'm going to talk about these different terms more to familiarize everyone with these terms, because most people, I think, hearing this talk today are probably having some degree of stenosis or some degree of instability, and these are the treatments that also apply to those pathologies. So there's posterolateral fusion, that's the traditional screws and rods in the back of the spine to hold the bones together. There's called ALIF, which is anterior lumbar interbody fusion, that's making an incision in the belly, in the lower abdomen, and replacing or cutting out the disc and putting a spacer in to restore the height that the disc used to be and to pack it full of bone to help your body fuse consecutive bones together. XLIF, it's another acronym. It means going from the side, underneath your ribs and above the edge of your hip, also going in your abdomen, taking the disc out, putting a spacer in. TLIF, similar approach, all done from the back of your spine, where you go and you take out a smaller amount of disc, you put a spacer in, you help it fuse. And 360-degree fusions, which is a term we use when we do something like an ALIF and an XLIF, along with screws and rods in the back. So it's combining ALIF and XLIF with a posterolateral fusion. All of these are done with bone graft, either an allograft from a donor or autograft from the patient themselves. And the second tower of treatment is disc replacement or disc arthroplasty. So going quickly through a couple of studies, there's a study in the Spine Journal, which is our best journal in the field, in 2001, which looked at patients that were treated for degenerative disc disease without stenosis, without instability, and compared these people to who were treated non-operatively. So there were 300 total patients, broke up into two pretty even arms of the study, so about 150 patients per side. They followed them for 2 years, and at 2 years, they found that the surgical group had 33% reduction in back pain versus 7% in the non-surgical group, 25% reduction in disability versus 6% in the non-operative group. They found depression rates were decreased by 20% in the surgical group and only 7% in the non-surgical group. And 63% of patients reported their outcome as much better or better than when they started versus only 29% in the non-operative group. Second study, more recently in the Spine Journal as well, looked at 75 patients, again treated for degenerative disc disease without instability, without stenosis, and followed them for 7.5 years. 42 of these patients underwent the ALIF surgery from the abdomen, and 33 patients underwent non-operative care. This is medications, physical therapy, activity modification. And they found at 7.5 years, the surgical group had lower reported scores of pain and disability compared to the non-operative group. They found a 52% reduction in pain and disability in this group versus only 15% and 0% in the degenerative disc disease group. Not surprisingly, they found that patients with single level disease that got single level fusions did better than people with 2-level disease who received 2-level fusions. But of note, there was a rate of almost 12% of development of adjacent segment disease in the fusion group. I think everyone is fearful of fusion surgery because you hear if I have 1 level fused, I'm going to need every other level fused. And in this study, they found at 7.5 years, approximately 12% needed to have or at least developed symptoms of degeneration at the level above the fusion. So it's not 100% of people. And of this group, not all of them had to undergo surgery ultimately to treat that. So the consequences of fusion, adjacent segment degeneration. This means that if you take away a motion level of your spine and you expect to keep on moving and functioning as you did when you had that level functioning well for you, well, you're going to start wearing out the remaining disc more. In general, people that have a level of their spine that develops degenerative disc disease, they're prone to develop it in every disc in their body if they live long enough. Now, if we go and fuse a level, so if we have a 1-level disease that looks more severe than the others and we treat that level, we're likely to accelerate the breakdown of the levels around it, but it's not necessarily the cause of the breakdown around it. Those levels are generally predisposed because of genetics to break down over time anyways, but we know if we fuse a level, we tend to accelerate that process. So different fusion techniques. This is more just to familiarize with people with these acronyms and give you some ideas of the range of complexity of surgeries that can be done. So the most simple surgery, the posterolateral fusion, this is screws and rods in the back. This is the workhorse of fusion for many years. The goal of the screws and rods are to stabilize the spine, hold it together, and give the body a chance to connect consecutive levels with bone. And looking at studies, there's very wide range of fusion rates published. A lot of surgeons want to believe that people fuse more than they really do when it's their patients and are more skeptical of others, but that's a bias of surgeons. In general, the fusion rate with posterolateral fusions is around 80%. The next group are interbody fusions. This is the more updated technology where now we remove part of the disc. Again, the disc space is a significant area of volume that we can occupy with bone ideally and take advantage of. So interbody fusions take part, most ideally, of the disc out and fill that disc space instead with a graft or a spacer and a bunch of bone. And the goal is that that's a lot of volumetric area that we can fill with bone to make a patient stable. So the goal of these interbody fusions are to restore disc height. So a patient loses height with degeneration. I think on the initial slide that Dr. Kent showed, the end stage of disc degeneration is that thin disc and then bone on bone arthritis. When that happens, we can put these wedges in and jack the disc back up to the height that you were born with, sometimes even higher than that, which gives your nerves more room and sets us up for fusion. When the disc is removed, we place the graft between the bones under pressure. So often this is pressed in there. And again, it's under quite a bit of pressure in order to jack the levels up because gravity and all your muscles are trying to pull the bones together. The different types of fusions. So again, this is for familiarity only. ALIF, or anterior lumbar interbody fusion. This is done through the abdomen, down low by the belly button. An incision is made. We pull your abdominal contents over to the side so they're not injured. And then the disc is removed and a spacer is put in. This is the original interbody fusion technique. It became more popular in the 1990s, and since then we've gotten better and better with our surgical techniques and the actual engineering of the cages themselves. And at this point, the fusion rate with these surgeries is very high. As we talked about, the new instrumentation and techniques we have made these more minimally invasive. Years ago, it used to be a very large incision with quite a bit of morbidity and an extended hospital stay. Now, most often, these patients go home the next morning. Down below, you can see an example of a wedge that was put in from the front of the spine, where you see two diverging screws put in. That's a device that can actually be used as a standalone device. So it doesn't need screws and the rods in the back to help support it. Frequently, we do put the screws and rods in back for additional support if we're worried about bone quality or worried there's a lot of pressure wanting to pull the bones apart. But these newer devices can be inserted without the necessity of using screws and rods in the back to help supplement for fixation. The advantages of this technique, overall, it's a very high fusion rate. It's higher than a posterior lateral fusion, so it's higher than just using screws and rods. It spares quite a bit of the dissection that's needed to put those screws and rods in the back, if you can get away just putting a cage with the two integrated screws through the abdomen. If somebody has pinched nerves because they've collapsed and you're able to restore a disc height, oftentimes you can obviate or get rid of the need of doing a decompression altogether. So if the nerves are pinched because the tunnels they used to live in collapse and you can restore the height of the tunnels, often you can avoid a decompression altogether. These spacers are very large and they can share the load of a very heavy spine, especially patients who are obese where there's a lot of extra load pushing on the bones. If we can put a very broad space spacer in, we can distribute the load of gravity and weight such that the bones can maintain their height. The disadvantage is it requires an abdominal exposure. So this is an abdominal surgery, like any abdominal surgery you've ever heard of. You're left with a pretty significant scar. And anytime you're in the abdomen, even if you are operate as careful as possible, there is a risk of injuring any of the organs or contents in the abdomen. Overall, that rate is relatively low, but in some studies as high as 10 or 15%. Lateral interbody fusion. This is one of the newer techniques. This is a minimally invasive technique where an incision is made underneath the ribs and above the hips on the side. You can kind of feel the soft spot where your love handles are. That area is exploited, and we make a minimally invasive incision there. We split muscle and are able to get down in the abdomen, down onto the bones, where the same process of removing the disc and putting in a spacer is done. The benefit of this is it's muscle sparing. It's relatively quick surgery with minimal pain at the site of the incision afterwards. There is certain risk. There's a risk that this surgery is done through a muscle called the psoas muscle, and we operate through the muscle. That way we are in a safe area. We're not anywhere around your abdominal contents or near the vessels that run in the front of your spine. And because of that, when you wake up, you frequently have pain in that leg because the surgery is done through the muscle. That pain is rarely permanent, but it's not infrequent for that pain to be present for several days after surgery. This technique can be used on any lumbar level with the exception of the L5-S1 level, which in the picture is the very bottom level you see. I'm not sure you can see my mouse, but it is the bottom level here. And it's because this white shadow you see projecting over, that's the edge of your hips on the side. And this 5-1 level sits below that. So it's difficult to reach that from the side because of your hips. Here's an example of what that looks like during surgery. The patient lays on their side. We use image guidance to make our incision. You can see it's a very small incision, about 2 inches here, to get down right onto the spine. And then the graphic on the right, you can see it's a tubular retractor that's used to remove the disc and then place the spacer in the disc space. And here's an example of what that looks like. This is one of my patients who had degeneration with collapse of the disc at L2 through L5. And you can see we put these spacers in, we'll restore the disc height and correct the overall curvature of the spine. The advantages of this, it's a minimally invasive surgery. It's a 2-inch incision approximately. It's a relatively fast surgery because we're able to avoid the large dissection necessary with the traditional abdominal surgery. It's reduced pain because of that. We are able to put a large spacer in there, which is important for patients with osteoporosis where their bones are weak. Again, this is a way we can distribute force over a larger area so the bones don't collapse on us. The disadvantages, we can't operate on the very bottom level with this technique. Sometimes the L4-5 level, the one right at the level of your hips, sometimes that can be difficult to access. And higher levels up in near your thoracic spine, your lungs come into play, and sometimes we have to put a chest tube in if we end up in the lung cavity. The next category is TLIF, or Transforaminal Lumbar Interbody Fusion. In this graphic, you can see the patient's back is right here. So this incision is all through the back. Surgeons that use this technique put screws and rods in and the cage all from a single incision. The advantage of this, it's a single approach. So again, rather than having an incision on the front and the side as well as the back for screws and rods, instead it's just one. It can be done through one incision, through everything done on the back. It also, because it's done completely through a posterior approach, there's no risk of injuring the abdominal organs. And at the same time, you can go manually decompress the nerves in the back. The disadvantage is this is a substantially smaller graft that's put in. And generally, we want to remove as much disc as we can and pack in as much bone as we can to maximize our chances of fusion. And with this technique, we're limited in how much disc we can remove, and we're putting in a relatively small cage, which is in the order of a third to a quarter the size of the grafts that can be put in from the side or the front. And finally, we have a limited ability to restore alignment. So again, we want to have a natural sway back in our lumbar spine. And with this technique, it's difficult to reestablish that sway back. Finally, circumferential fusion. This is a combination of anterior and posterior fusion. The goal of this is to maximize stability. This was initially developed for scoliosis surgery and instability surgery, and has more recently been employed for more common degenerative conditions. The benefit of this, it's maximal fusion rate and the maximal ability to create a proper alignment. The disadvantage is this is more surgery. With not using modern techniques, this could lead to substantially longer operative times and more blood loss. However, with advancements in surgical techniques, these surgeries are becoming significantly faster, safer, and less invasive than they were even 10 years ago. Finally, total disc replacement. Again, for degenerative disc disease without instability and without stenosis, this can be the ideal population to use this technology. So with this technology, a disc is removed and a fake disc or an artificial disc is placed. This is not a fusion surgery. This is substituting out a painful disc for a man-made disc that maintains their motion. The ideal candidate for this would be a patient with isolated back pain without leg pain, and a patient who doesn't have facet degeneration. Again, we talked about the tripod with a large disc in the front and two facet joints in the back. We'd want the joints in the back to be relatively normal looking, at least on imaging. Why? Because we replace only the disc in the front and we don't touch the smaller joints in the back, the facet joints. So if you don't touch those and they're diseased, you'd be left with quite a bit of back pain. But in the patient who doesn't have significant degeneration in those supporting joints and their problems confined to the disc joint itself, this can replace the painful joint and leave the patient with substantial pain relief. There is quite a bit of literature and advertising in the media about this technique. These companies are very smart about the way they advertise. The outcomes of this are strictly driven by patient selection. If you take a patient with quite a bit of instability and try this technique, it will not work and it will be demonized. However, if you pick the correct patient, this technique does work very well. So in summary, degenerative disc disease without stenosis, without instability is a broad topic, and it can often mean that it's back pain, but not necessarily does it mean that the disc itself is the cause of the pain. So if someone reads an MRI report that says degenerative disc disease, that must be why I have back pain. It's not always true. It can be, but by no means is it a definitive connection. Surgical treatment for degenerative disc disease is a very rare entity. In general, people with degenerative disc disease will benefit from non-operative techniques. However, in the correct patient where everything else is excluded and every other treatment option is exhausted, surgery can be indicated. The results from surgery are highly variable. And again, I keep on saying this, patient selection is by far the most important characteristic. All right. That's what we have for our talk thus far. So we'll open it up to questions at this time. Our producer here is writing the questions out for us. So how successful are surgeries to remove bulge disc? So I'll take this one. Yeah. So in general, I tried to narrow this talk down to surgeries for diseased discs without specific herniations. The problem is when people describe disc problems, they use a lot of terms interchangeably. People can have bulge disc, herniated disc, extruded disc, there's a lot of synonyms we use, and people would like to think that these terms have very specific meanings, but they oftentimes don't. So patients with herniated discs, so a very focal or very specific area, often on one side or the other, that herniates, surgeries that remove those pieces of disc are usually highly successful. In general, if somebody says, I have one-sided leg pain, and then we look at their MRI and they have a herniated disc that's specifically on that side, and the patient traces out the pattern where the leg is bothered and it lines up on the MRI with the known dermatomes that we have, then and oftentimes those surgeries are very highly successful. And even in those patients, non-operative therapies are often very successful. When it comes to disc bulges, it depends on how big the bulge is and what it looks like, which is why it's hard to compare apples to oranges here. This is one of the probably the most common topic I discuss in clinic is when someone says, I was sent to you because I have a bulge disc, do I need surgery? And the answer is, it depends. And it depends on what that bulge looks like and what the symptom is. All right, the next question, also for me. Do laminectomies help bulge discs? It's somewhat of a two-part question. So when people have stenosis, it's the nerves being trapped, and when nerves are trapped, they're trapped from a combination of things. Nerves live in the spinal canal, but the other things that can contribute to the spinal canal are discs that bulge in and occupy part of the room, facet joints in the back, which can overgrow and get bone spurs, fat, which can make its way into your spine, and ligament that overgrows. So there's a canal that you're born with, and any number of things can start competing for space. A large bulge disc in a canal can sometimes occupy so much space the nerves get pinched. If that's true, laminectomies, which is removing the posterior part of the bone, can be performed to open up the canal. So oftentimes, even without touching the disc, if a laminectomy is performed and done well, it can create enough new room in the canal that the nerves can become happy again. So it can be a successful treatment for people that have a bulge disc. But with that said, laminectomy is not necessarily the treatment for all bulge discs. Some discs bulge and don't pinch nerves in a way that irritates them. And sometimes discs bulge and they create some back pain, but not any clear leg pain. And in those patients, a laminectomy would be unlikely to help them.
I think just to add to that, when you think about laminectomy, you're talking about what's called a direct decompression, meaning a surgeon's going in and actually decompressing the nervous tissue to kind of open things up. The vertiflex procedure is something that, from a pain side, that has been becoming more and more popular and works very, very well for patients who have these bulges that are contacting these nerves and have very specific symptoms that improve with various positions. And so that can also be an option to do what's called an indirect decompression to help give patients pain relief without needing a larger surgery.
All right, the next question, what treatments help me avoid surgery? I'll let you take
I can start with that. So, we talked a lot about, a lot of different options, for a lot of these bulge discs, oftentimes time. So things can be very serious and extremely painful, but vast majority of people will get better with time. And sometimes we just need to get the patients through that time using a bunch of different therapies, whether that be epidural steroid injections, it can be medications, physical therapy, working on core strengthening, helping patients support lose weight. All these things can help promote these bulges from basically healing themselves and no longer pushing on the nervous tissue. And so those are going to be the things that, for us at Axis Spine, we have both, fellowship trained spine surgeons, fellowship trained pain docs. And so we, work closely together to make sure that if a patient needs surgery, we get you to the surgeon right away. But if there are things that we can do to avoid having a surgery, that's often the realm that the area that I fill is to provide a bunch of different treatment options. So hopefully you never need to see Dr. Blizzard.
I'm not offended by that at all. In general, surgery is only ever urgently needed in a very small subset of cases. When patients have clear progressive weakness, so somebody that says, I was walking normal a week ago and now I'm walking very abnormal, I can't lift my leg, I can't get out of bed, I'm in dire straits, that's one category. So very severe weakness, we generally want to more urgently talk about surgery. People that are needing very high dose narcotics to survive life is the second category. In general, we know that people on long-term narcotics, there's an unbelievable number of risks, which are becoming more and more publicized in the media, and they are accurate. I mean, people on long-term high-dose narcotics, it's a danger. It's hard to get off of them, and they have quite a few complications. So patients that require very high-dose narcotics to survive life would be the other category that I would not necessarily want to wait on for surgery. But anything short of those, if it's me personally, I would try to exhaust everything but surgery before talking about surgery. It's not because surgery is not successful, it's because surgery has more risk than everything but surgery. So in my mind, you need to exhaust everything else first, and when nothing else works and you remain miserable, that's the time to think about it. And you know, the tincture of time aspect of treatment is not to be forgotten. Your body wants to help you, and a bulge disc, your body can oftentimes make look better. It can make less significant over time. That's the idea of getting an MRI and repeating it. Why do we often repeat them? Because oftentimes your body will try to repair it if you're able to tolerate the symptom long enough.
All right, next question. Can you explain more about spinal cord stimulation? You want to give that one?
I'll give this one to you.
So spinal cord stimulation, it's a two-part procedure. You come in, the first part is you come in and under a little bit of sedation, we basically put these small wires that go right along the spinal cord in the epidural space, which is a potential space that's not in the spinal cord but sits right behind it. We put these wires in there, they come and they kind of are outside, they come and are externalized, so the battery pack sits outside for the trial. And basically you try the therapy over a week or so to see if by blocking these pain signals, if that's going to help your symptoms. If it does, then you come back, we take those wires out and we get you scheduled for an outpatient surgical procedure that it does the exact same thing. We put the wires in the exact same spot, but instead of having those wires come outside the skin, the battery is put underneath the skin. Sometimes we work with our surgical colleagues, depending on the clinical situation, the patient, and sometimes we'll have our surgeons put these in, and they'll put what are called paddle leads. Paddle leads are essentially the same thing. They're both delivering, energy to the spinal cord, but instead of us just making a little puncture wound in the back and to put these little electrodes in, we'll have our surgeons basically take out a small amount of bone and then basically suture these kind of long, they're shorter but wider leads to that epidural space right where they need to be. In order to keep them so that it doesn't shift around as much. And that can be something that can be also an option for patients, especially patients who are very active or have had problems with these lead migrations in the past, or if there's been a lot of surgical hardware placed, and sometimes we need our surgeons to help with that. And so I hope that answered the question.
All right, here. Next question is, a patient has back pain and leg pain after laminectomy and fusion surgery. What should they do next? Very loaded question. The most important thing is it's time to get repeat imaging and time to be assessed. So decompression and fusion surgery encompasses many different techniques, and the solution for what's done for ongoing symptoms afterwards depends upon what this problem was before surgery, what was done during surgery, and what things look like now. So the answer to that is it's a very case-by-case discussion, but it involves understanding what was done and why it was done, what improved, and what remains.
And just to add to that, back pain, there are many different causes of back pain, and a lot of these symptoms can overlap. And so for the reason you had back surgery may not be the reason you have pain now. And so that's why Dr. Blizzard, I agree, you need to have some additional imaging to make sure that the reason you had surgery hasn't, returned, or, if there isn't a complication or something as a result of the surgery. But you need to keep in mind that, if you had some sort of decompression or fusion, or, to help with some instability, or to open up those nervous tissue, now you're exposing your body to they had to go through a lot of muscle and tissue to basically get access to your spine to do the surgery. You have arthritis probably at baseline, and so is now your pain more related to arthritis related issues. And then there's going to be a subset of patients who we can't identify a cause of back pain, and that's this term that's born out, which is unfair to our surgical colleagues, but it's called failed back surgery syndrome or post-laminectomy syndrome, which basically means you have back pain or back pain down your legs. We don't know what it's from. We've tried a bunch of different diagnostic tools and we can't identify it. but the pain's still there and it's severe. And so for those types of patients, that's where spinal cord stimulator therapy has really taken off.
All right, the next question is, I think I have a bulging disc. Where should I start? Excellent question.
So if you think you have a bulging disc, what you should do is you should talk to your primary care doctor or give us a call and come in and get evaluated. Oftentimes, if you think you have a bulging disc, you need to have a physical exam. You need to have a trained medical professional, evaluate your symptoms and see if imaging or any sort of other more conservative therapies are needed before you even need imaging. And based on the symptoms, based on the whole clinical picture, if an image or an MRI or such is needed, then that will be obtained, and then you can start coming see us, either Dr. Blizzard or myself, to see if the symptoms that you have are kind of fit with what's going on that we see on the imaging. Because those are the patients that do best with our therapies, is if we can see something that's going on in the spine and the symptoms match those symptoms, those findings. And then we have many different tools that we can use to kind of fix those.
So a question I actually get relatively frequently is, how do we get to see you? So we have many patients who are spread across the area, and previously we required that people had referrals from their primary care physicians to see us. However, now you were able to get an appointment at our clinic by calling here without a referral, and that process of dealing with insurance companies, which is a black box that I do not totally understand. We have a whole crew of people here who understand the system and how to work it to your advantage, such that you can get the care you want in a timely fashion. So our goal overall is to help reduce the period of time between somebody having symptoms and getting to see somebody who might have the answers for them.
Yep. Here, Dr. Blizzard and I here at Access Spine, we're part of a great group here. We're the only comprehensive pain and spine center in the region. We offer, fellowship trained orthopedic spine surgeons. We have fellowship trained pain physicians, interventional pain physicians. We also have chiropractors, and we have physical therapy. We do some weight loss management, bone mineral, bone health. What else do we do? I think I pretty much named it all. But.
The benefit of, again, we have all this under one roof here. We previously were spread across multiple buildings, but maybe on our next webinar here, we can bring you and give you a tour of this facility, because it's massive. But the benefit we have is we're all under one roof, and it's very easy to communicate between the groups. So if somebody is seeing a chiropractor can literally walk over to my clinic and ask me a question, and we can get an answer immediately. And I know for me personally, navigating the health system with my family, getting from one doctor to another can be a huge hurdle and a huge lag time to have certain offices talk to other offices. And the benefit we have here is that if you transition between needing non-operative care and operative discussion, but you want to go back to non-operative care, that's done seamlessly here. So there's not a long delay trying to get back in, reestablishing the system with an unnecessary wait time. And obviously, as a group here, we're trying to do our best to limit these wait times people have, so we can get to addressing their symptoms as soon as we can.
And if you want to come see us, you want to see a surgeon, just get an appointment. You may be scheduled with a pain physician, you may be scheduled with, a nurse practitioner, a physician assistant, but the quickest way to see a spine surgeon is to just come here and be evaluated. Because if we find something that needs to be urgently seen by our spine surgeons, we can get you in often that same week, maybe even the next day. And so you just need to get an appointment, and at that point, we can get you to where you need as expedited as possible. Okay.
All right. I think that wraps this up. Appreciate you guys all tuning in. Any other questions you guys have offline? We are going to record the questions, and we can do our best to get back to you guys on a one-by-one basis.
All right. Thanks for joining us.